Thank you.
Thank you, Professor Suhail, for your nice remarks. Any other questions? So we may proceed to the next presenter, Dr. Abdelhamid.
نرجع تاني للكالسيوم. يمكن احمد علاء خلى مهمتي مش عارف اسهل او اصعب، بس حاول for the flow I'll keep the presentation as such as previous. Michael. Calcium is the most abundant mineral in the human body. It's critical for many processes in the body, including blood coagulation, platelet adhesion, neuromuscular activity, endocrine and exocrine secretory functions, bone metabolism. Most of the serum calcium is stable في البون. حوالي 99% موجود في البون as hydroxyapatite، 1% بس هو موجود في البلد زي ما احمد علاء قال، 50% موجود في صوره free form، و 50% is bound to albumin و bound to other ions. With a normal serum calcium of 8.5 to 10.5 and ionized calcium from 4.2 to 5.2. عارفين ان الكالسيوم هوميوستاسيس بيعتمد mainly على باراثايرويد هرمون اللي هو بيشتغل على 3 main organs. على البون بيعمل calcium and phosphorus reabsorption, bone reabsorption and calcium phosphorus release. على الكيدنيز بيعمل 2 functions, calcium reabsorption, phosphorus excretion and activation of vitamin D into 25 hydroxy vitamin D اللي هو بدوره بيشتغل على الجي اي تي بيعمل absorption of calcium and phosphorus. ده to maintain the serum calcium in the normal range. Plasma proteins act as calcium buffer. يعني transit decrease in the serum calcium بيؤدي إلى release of the calcium bound to serum albumin. This buffer is sensitive to the pH. Increase in the pH, like in alkalosis, will be associated with a decrease in the serum calcium and vice versa. Calcium measurement ممكن نعتمد على ionized calcium. The more physiologically relevant, but it's neither the cheapest or the easiest. يعني ده مش أسهل حاجة ولا أرخص حاجة، بس ده the best لو الالبومين is abnormal. Total calcium ده أسهل وأرخص، وممكن نستخدم الايكويشن اللي احمد قالها اللي هي corrected calcium يساوي serum calcium plus 4 minus measured albumin في 0.8. بس ناخد في الاعتبار ان الالبومين برضه بيتعرض للتشينجز نتيجه pH, drug fatty acid bound to albumin, calcium binding immunoglobulin and gadolinium containing agents. وبالتالي in critically ill patients الاحسن ان احنا نميجر the ionized calcium. Acute hypocalcemia, the most common cause is post-operative hypoparathyroidism. وده اللي خلى الجايد لاينز او يبقى فيه جايد لاينز to detect who will not develop permanent hypoparathyroidism post-operatively. عشان كده they recommend measurement of the serum PTH 12 ل 24 ساعة following thyroid surgeries or neck surgeries with a cut-off of 10, cut-off point of 10. الناس اللي هم عندهم PTH أكتر من 10 picogram per milliliter most probably they will not develop permanent hypoparathyroidism والعكس صحيح. Other causes للهايبوكالسيميا غير البوست سيرجيكال hypoparathyroidism زي ما احمد قال idiopathic او autoimmune او PTH resistant في السودو hypoparathyroidism او abnormalities في الفيتامين دي سواء vitamin D deficiency او abnormal vitamin D activation like chronic kidney disease او liver disease او vitamin D resistance, vitamin D rickets, dependent rickets او لو في calcium deposition او complexation مع الفوسفات في حالات الهايبرفوسفاتيميا زي في حالات الرابدومايليسيس او تيومر لايسيس سيندروم او complexation مع fatty acid في حالات الاكيوت بانكرياتايتس او citrate في blood transfusion او excessive skeletal mineralization زي في حالات osteoplastic metastasis او في حالات post operative hangry bone syndrome. في الاي سي يو سيتنج الهايبوكالسيميا ممكن ليها اسباب كتير، ممكن تبقى poor nutrition, vitamin D deficiency, renal disturbances, acid-base disturbances, inflammatory cytokines, magnesium disturbance أو blood transfusion including desiccated blood. The clinical picture بتعتمد mainly على حاجتين: the degree and the rate of decline. يمكن the rate of decline ياخد ال upper hand في ال clinical manifestation. An acute decrease في blood calcium enhances the neuron excitability, but chronic hypocalcemia ممكن تبقى asymptomatic حتى لو وصلت ل low level. Severe hypocalcemia is usually associated with predictable signs and symptoms. وبالتالي الديفينيشن عشان نقول دي acute hypocalcemia او الحاجه اللي هي warrant ان احنا لازم take action و I think need to be managed in the ICU. ان severe hypocalcemia is a total serum calcium اقل من 7.6 milligram per deciliter and or ionized calcium concentration below 3.6 milligram per deciliter or any acute symptomatic hypocalcemia. This is an urgent medical condition and warrants treatment. Clinical picture في manifestation للacute conditions زي perioral numbness, paresthesias, muscle cramps, weakness, carbopedia spasm, tetany, seizures, laryngeal spasm or bronchospasm, confusion, delirium, congestive heart failure, prolonged QT interval أو arrhythmia. في other features للعيانين اللي هم عندهم chronic conditions زي subcapsular cataracts, dry skin and hair, papilledema, pseudotumor cerebri, depression and dementia. ودول classical tropistic and Rousseau signs. لما يجي patient عندنا manifestations دي ايه الانفستيجيشنز اللي احنا هنعملها؟ اول حاجه serum calcium or the ionized calcium like we have said before, phosphate, parathyroid hormone, urea and electrolytes, vitamin D and serum magnesium. Serum intact PTH, like Professor Serhat just said, is the most important. It can be only interpreted correctly when serum calcium is measured simultaneously. هنلاقي serum PTH قليل او inappropriately normal in hypoparathyroidism او ممكن يبقى عالي في حالات السكندري hyperparathyroidism due to vitamin D deficiency او chronic kidney disease او في حالات السودو hypoparathyroidism. بالنسبه للفوسفات هنلاقي فوسفات عالي في حالات الهايبوباراثايروديزم او سودو هايبوباراثايروديزم او قليل في حالات السكندري hyperparathyroidism due to vitamin D deficiency او due to poor nutrition. Special caution لما نلاقي الفوسفورس اكتر من 6 ملغ بر ديسيليتر عشان احنا لما نيجي نعوض بنخاف ان يحصل extraskeletal calcification or metastatic calcification. Vitamin D needs 25 hydroxy vitamin D and deficiency is less than 20 nanogram per ml or insufficiency less than 30 nanogram per milliliter. Alkaline phosphatase ممكن نلاقي elevated في حالات الفيتامين D deficiency او في حالات osteoplastic bone metastasis. A treatment, it is a medical emergency that warrants hospital admission. أول ما نشوف البيشنت بنديله IV calcium gluconate in the form of 10 milliliters of 10% calcium gluconate in 100 مللي dextrose 5% over 10 minutes. بس دي حاجة acute مش هينفع نعتمد عليها لوحدها بس. This can be repeated until the patient is asymptomatic and this is followed by calcium gluconate infusion in the form of 100 مللي of 10% calcium gluconate يعني حوالي 10 vials أو 10 ampoules in 1 liter of normal saline or dextrose 5% over with an infusion rate of 50 ل 100 milli per hour. Titrate the rate of infusion till normal calcemia and continue until treatment of the underlying cause has taken effect. الكلام ده لازم يبقى في setting in the hospital setting لأن احنا هنحتاج نعمل monitoring the patient with an ECG and calcium to be measured every 1 to 2 hours until stabilization, then every 4 to 6 hours. احنا عندنا في كالسيوم كلورايد and calcium gluconate. although calcium chloride ده بيدي 4 times elemental calcium عن الكالسيوم gluconate إلى أنه لو حصل منه extravasation ممكن يعمل severe tissue necrosis. ودي واحدة من ال uncommon hazards لل IV calcium زي local thrombophlebitis, cardiotoxicity, hypotension, calcium choky taste, nausea and vomiting, sweating and flushing. وسبيشال كوشن في الاي سي يو لو البيشنت بياخد ديجوكسين اللي بيزود السنسيتيفيتي للكالسيوم فممكن يبريسيبيتيت اريثميز. في نفس الوقت بندي البيشنت الاي في كالسيوم لازم نبتدي initiate the oral calcium and vitamin D therapy as soon as possible. We are gradually tapering the IV calcium. Special caution لازم نبص على السيرم magnesium. And any correction of the serum calcium without correction of the magnesium is only transient. Then hypomagnesemia is one of the causes of refractory hypocalcemia and hypokalemia. أي precipitating drug like Dr. Ahmed said لازم نوقفه. بندي administer أو ندي magnesium sulfate 2 gram في 20 milliliters of dextrose 5% over 10 to 20 minutes. Then بقية اليوم ممكن نكمل infusion 4 to 8 grams of magnesium sulfate over the next day لو the patient needs. حاجه ثانيه الانتراسيلولار magnesium deficits are generally large و inappropriately mirrored by the serum magnesium. فاحنا بندي patient IV magnesium وعنده magnesium deficiency لازم نديله oral magnesium and should be maintained on it. بالنسبه recombinant PTH in acute setting, the experience with the use of PTH in the acute setting is too limited to make any specific recommendations. The chronic management of the hypocalcemia should be tailored to the underlying etiology, and mainly in the form of oral calcium supplements, vitamin D metabolites, thiazide diuretics, recombinant PTH. The goals of therapy is to control the symptoms, the calcium level in the lower half of normal or just below the normal. Avoid hyperphosphatemia with the calcium phosphate product below 55, 24-hour urinary calcium below 300 milligram per day, normal magnesium and normal vitamin D. The oral calcium supplement, the most efficient calcium carbonate containing 40% elemental calcium and calcium citrate containing 21% elemental calcium. A starting dose is 0.5 to 1 gram of elemental calcium 2 or 3 times every day. But remember that there is an absorptive capacity for the gastrointestinal tract of around 500 milligram per time. So بدل ما ندي العيان مره واحده دوز كبيره ممكن نخليها more frequent doses, small doses but more frequent. الابزوربشن بتاعها هيبقى افضل. فيتامين دي بندي لو البيشنت عنده فيتامين دي deficiency بندي 50,000 international unit of vitamin D2 or D3 weekly لمده 8 ل 12 اسبوع لغايه ما نوصل لليفل اكثر من 30 نانو جرام per deciliter and maintain the dose. ندي maintenance dose of 1500 ل 2000 international units per day. Remember that in the patients اللي هم عندهم hypoparathyroidism are not just deficient in one hormone. They are deficient in 2 hormones, the PTH and deficient in 125 hydroxy vitamin D. ممكن نستخدم activated vitamin D analogs زي 1 alpha hydroxy vitamin D, especially in the patients عندهم renal failure أو عندهم hypoparathyroidism. This produces a rapid onset of action. Hypercalcemic events actually are more, but are easily reversible and they are short acting. IV forms of the activated vitamin D analogs are also available. بنستخدم calcitriol أو alpha calcidone in a dose of 0.25 to 3 microgram per day in 2 to 3 divided doses. Remember that the steady state is reached after 5 to 6 half-life, and dose adjustment need to be done every 2 to 3 days. Thiazide diuretics, we use, as we mentioned before, احنا بنمونيتور urinary calcium excretion. والhypercalciuria اللي هو urine excretion أكثر من 300 ملغ per day. ممكن نستخدم thiazide diuretic to avoid that. نستخدم الدوز من 50 ل 100 ملغ per day. Hyperphosphatemia, ask the patient أو بنقول للبيشنت هو يقلل dietary intake of phosphate في حاجات اللي هي phosphate rich food stuff زي الميت والاج والدairy products, and oral phosphate binders can be used, especially لو استخدمنا الكالسيوم within the meat. يمكن في studies كتير حوالين اليوز of the recombinant PTH في حالات الهايبوباراثايريزم حتى لو كانت post operative hypoparathyroidism. دي كانت study و systemic review and meta analysis كان لسه to be published يعني. فهم شافوا ال PTH therapy versus standard of care therapy, يعني كل standard of care therapy اللي احنا قلناه قبل كده فلقوا ان ال use of the recombinant PTH was associated with more reduction في phosphate level, more decline or more reduction في calcium and vitamin D doses, but was associated with more hypercalcemic episodes. فكانت the recommendation of the panel in هم in patients with chronic hypoparathyroidism, the panel suggested conventional therapy as a first-line therapy. When conventional therapy is deemed unsatisfactory, the panel considered the use of PTH. PTH replacement therapy is recommended when the patient are not adequately controlled with the standard of care therapy, especially if the patient has symptomatic hypocalcemia, hyperphosphatemia, renal insufficiency, hypercalciuria, or poor quality of life. ونفس الكلام اكدت عليه ال European Society of Endocrinology لسه من كام يوم. برضو اكدوا ان ال use of the recombinant PTH is not for all the patients. My final take-home message: acute hypocalcemia is a medical emergency. Post-surgical hypoparathyroidism is the most common cause. Acute or severe will present with manifestation of neuromuscular excitability. Acute, the patient needs IV calcium and correction of magnesium deficit. The chronic is a treatment. Chronic treatment is a treatment of the cause: oral calcium, oral vitamin D, thiazide, with a question mark on the recombinant PTH. Finally, thank you.
Dr. Ahmed, thank you a lot for a very nice presentation. So, any questions